This is chapter 47, reproductive assessment. There's not a lot of information in the reproductive assessment, just as there's not a lot of hands-on assessment techniques. It's mostly diagnostics, just like renal. So we divide it into two parts, male reproductive, female reproductive. We also need to know that the reproductive system is important because it produces hormones that are important for biological development and sexual behavior. When we talk about the male reproductive system, we're talking about testes, scrotum, the ducts, the glands, the penis, and breast are also included in male reproductive. When we talk about diagnostic tests for male reproduction, one of the big tests that is seen a lot, especially in older males, is a PSA, which is the prostate-specific antigen. This is a blood test that's used to help diagnose prostate cancer and also to monitor treatment. You can also do an ultrasound of the prostate, where we're trying to look for the actual prostate size. We're looking at masses or torsions. You can also do a biopsy, and when we're doing a biopsy of the prostate, we're trying to diagnose cancer. They can do a transrectal biopsy or transurethral. We also are talking about assessing male and female. We're also talking about STDs, or what now they use the term STIs, sexually transmitted infections. So they can do a gonorrhea culture. It's usually a swab where they put the smear on the slide and they conduct a gram stain in order to identify that it is positive for gonorrhea. The sample can be taken from the urethra, the penis, the anus, or the throat. Any affected area is where they're going to take it from. When they are doing a syphilis screening, there are several different ones that can be done. There's one called a VDRL, an RPR, or an FTA-ABS. They're looking at positive findings are usually made within 1 to 2 weeks after the primary lesion appears, and that usually occurs 1 to 4 months after the initial infection. The FTA ABS is actually considered the most accurate and is often used if the findings of the VDRL and the RPR are kind of questionable and they can't really make a diagnosis. You have to remember, with a lot of STDs and STIs, patients or people have no symptoms and they are carrying and transmitting back and forth and not really knowing that they are because they don't have initial symptoms. So education is always the biggest key, especially when we're talking about STDs and STIs, and communication between partners, practicing safe sex, educating patients on safe sex. And if you do have, where you're working maybe in a clinic and you are doing multiple STD or STI cultures, making sure that they know they have to inform their partners in treating everybody as a whole. So when we talk about male, we're still talking about male reproductive, we're talking about the health assessment interview. When we talk about male and female reproductive, sometimes this is kind of a sensitive subject. Not everybody wants to walk into a clinic and say to someone, well, I just slept with 20 different people in the last year and I think I have an STD. It's not really something they may want to be forthcoming about. So you have to be very cautious in how you approach, how you ask questions, so that you can get the most accurate information. You also need to take in consideration genetic considerations. When we think of male reproductive, prostate cancer, testicular cancer are two of the big ones that are considered genetic considerations. Age-related changes. You do have changes in the prostate gland where there's usually older men who have some type of benign prostatic hyperplasia, so they usually have some type of enlarged prostate, but it's not an indication of prostate cancer. Other things that can come up is you have patients with chronic illnesses, such as diabetes and renal failure, that can cause issues in regards to male reproductive. Certain medications and treatments and illnesses can cause impotence. There is also now, well, not now, but you see a lot more on TV commercials for erectile dysfunction, but certain medications may be the culprit of that. So maybe not only just asking the patient about erectile dysfunction and if they have it and how it's occurring and what's going on, but you may have to also ask, what medications are you taking? Are you taking any new medications, any new hypertensive, beta blockers? The other thing too, when we talk about male, asking when we're talking about medication, do they take Viagra? We know that that plays an important factor if they are a patient who can take nitroglycerin. Education too, in regards to younger males, we want to start education for testicular exams or self-testicular exams at age 15 or younger, because this usually occurs early. So when we're talking about the male actual physical assessment in regards to reproduction, you have the interview questions on page 1633. You do include the breast and the axillary and the lymph nodes in this particular assessment, because you can have patients who have gynecomastia, where it is actually breast tissue or breast enlargement of the breast in men. And if that is occurred or that is going on, they have that potential risk of having breast cancer. So men, yes, can get breast cancer. So if you feel, or if you need to instruct them to feel that if they have a hard, irregular nodule in the nipple, that could be suggestive of breast cancer. It's very distinctive. That's not only for men, that's also for women. Inspecting the penis, the urinary meatus, inspecting the scrotum. There's something called, sorry, I just marked right on your screen. Something called transillumination, which is just essentially a light shining on the actual scrotum. If there were masses, you would see a dark shadow. For purposes of regular routine nursing, you guys are not going to conduct a prostate exam. That is something that is done by the physician or the nurse practitioner. It is something that you should encourage your patients to have done on a regular basis as part of the routine physical. Now, when we think about female reproductive, all the components that are housed into the female reproduction or female assessment or anatomy is external genitalia, the mons pubis, the labia, clitoris, the actual vaginal opening, urethra opening, the glands, and then we have internal genitalia, the vagina, the cervix, uterus, fallopian tubes, and ovaries. So just a few more things with female reproductive. That you have the Bartholin's and Skene's gland. These secrete lubricating fluid during the sexual response cycle itself. You can have a non-tender mass that is postlateral of the labia, and it's typically known as a Bartholin's cyst. The clitoris is equivalent to the penis when we think of in terms of sexual intercourse. The uterus is actually pear-shaped. It does consist of 3 parts. It has the fundus, the body, and the cervix. That's important when we start to talk about pregnancy. So when we talk about diagnostics for the female reproduction, we consider genetics. Of course, also with female genetics, the biggest is breast and ovarian cancer. There is something called the BRCA1 and BRCA2 gene that can be tested to see if you have a predisposition to breast and ovarian cancer. That particular test is a blood draw test. It is extremely expensive to have that done, and a lot of times insurance will not cover it. Anytime there has been a history of colon, breast, or endometrial cancer, there's a higher risk in the woman's family. Now we're going to talk about just a few of the actual tests that can be done. There's something called a colposcopy. So women on routine basis go to their OBGYN and they have a pap smear where we're actually taking cells to determine if there's any abnormality in those cells, possibly indicating cancer. If you have a pap smear that detects cell changes in the office, then what they will do is maybe set you up to come back and have a pap smear repeated in 3 months, and or they may also have you have a colposcopy done. The colposcopy is done in the healthcare provider's office. Typically the OBGYN will do it in their office. They take a microscope, they're visualizing the cervix, and they usually take a biopsy of the cervix. They can also do cryosurgery, which is freezing. If there's any kind of abnormal cells, they can freeze them to stop their growth. You do need to instruct the female, and a lot of these female reproductive diagnostic tests will tell you to tell the woman not to douche. That is something I don't think a lot of women do anymore. That used to be big a long time ago. So they should abstain from douching and intercourse for 48 hours prior to the exam. You do need to make sure that the woman is not pregnant. Post-procedure, you need to tell her that there may be slight vaginal bleeding for a couple of days, and she also needs to abstain from vaginal intercourse for 1 to 2 days. She can take NSAIDs for discomfort or cramping. Then we're going to talk about something called the Leitz procedure, which is loop electrosurgical excision of transformation zone. So they call it Leitz, L-E-E-T-Z. We're evaluating the cervical cancer, or we're treating cervical abnormalities. This is done as an outpatient procedure, usually requires general anesthesia, and typically they're in the recovery room an hour to 4 hours, so it's kind of like your in and out surgery. Post-op, you need to tell the patient she needs to rest for 2 to 3 days. She may have minor vaginal bleeding or discharge that will occur for several days. Spotting may continue up to 3 weeks. She has to use pads. She cannot use tampons. She does need to avoid sexual intercourse and douching until all the vaginal discharge has stopped. She needs to notify the physician if she has any increase in bleeding or any type of signs of infection, fever, chills, foul-smelling discharge. The other procedure is an endometrial biopsy. This is performed to identify endometrial hyperplasia or endometrial cancer. So they're actually cleaning the cervix. They take a tissue and they do this transcervically from the endometrium by curtilage or a vacuum aspiration. So there is a lot of pressure and it is painful. It is brief, but it is painful. Causes vaginal bleeding for a couple of days. You need to tell the woman she needs to wear pads and avoid tampons and sexual intercourse while she is bleeding. Just like the male reproductive, they can also have the gonorrhea culture or the syphilis culture or any type of cultures or testings for STDs. The other thing that we talk about when we talk about women is HPV test. This is where we're testing for human papilloma test. This is usually a test screening tool in women after the age of 30. It is usually conducted in conjunction with a pelvic examination. A positive test for HPV indicates the presence of a high risk for cancers, but does not specify what type may be present. The test is usually done during the time when a woman is not having her menstrual period. She should refrain from douching and the use of tampons or any vaginal type medications for at least 48 hours prior to the exam. She does need to avoid prior to the examination. Explain to her that she may have small amounts of vaginal bleeding or gray-green discharge. When we're talking about a histosalpingogram, we are looking to try to diagnose infertility or abnormalities of the uterus, fallopian tubes, and they do use dye. They do take pictures. This test is done on the 7th to 9th day after the end of the menstrual period. Need to assess for pregnancy, vaginal bleeding, or any type of infection. Assess for allergies for seafood or iodine. The woman may be asked to use an enema, or she may have to douche prior to the test. There may be some bloody discharge 3 to 4 days after the test. If it continues after the 4th day, then she does need to notify her physician. Then the patient can have a laparoscopic test. This is where we're going in to visualize the organs of the peritoneal cavity. So we're looking at the uterus, fallopian tubes, and ovaries. They can withdraw fluid. They can do a tubal ligation. So a lot of times you may have, if you're on postpartum, a patient who has 3 children and no longer desires to have any more children. So if she's scheduled maybe for a C-section, she may have already discussed with her physician to go ahead and do a tubal ligation while they're in there, and they will do that at the same time. If not, it's something that she can come back and have done as an in and out procedure, and it's just done laparoscopically. So as far as nursing interventions, no smoking, no eating, no drinking fluids after midnight. She may have to take laxatives or enemas. It just depends on the protocol. Usually I'm not in recovery room very long, about an hour. After she voids, she can go home. They'll usually give medications for pain or discomfort. She may experience pink tinge, discharge, or drainage from the abdominal incisions. It's usually 4 little incisions on the abdomen that you would assess, and they're not very big. A Band-Aid usually goes over them. Usually the drainage will last up to about 48 hours. You may have shoulder pain. You have that referred pain from them filling your belly up with gas in order to do the actual procedure. She may have some vaginal bleeding, but any excessive bleeding, pain, or signs of infection needs to be reported to the physician. You can also do a abdominal and or vaginal ultrasound where they're looking for fibroids. You want to increase the fluids. You do not want the patient to void prior to the test. I think the other thing we did not talk about is the mammogram. Mammograms are done to detect tumors of the breast. They're usually routine. Your textbook says that recommendations for some groups are women over the age of 50, and they should have this exam every 2 years. The American Cancer Society, however, says that you should have an annual examination starting at the age of 40 and over. This has been controversy with insurances for a while. If you have a family or a strong family history of breast cancer, you should really discuss with your physician what your plan should be as far as mammograms go. So when we're talking about the actual physical assessment itself, it's the same as with male. With female, it's self-breast exams. It's a very important key to teach and to educate and for them to be proactive. If they have very dense breasts, which means they feel like they're just full of knots all over, they may need to be educated that they need to discuss with their physician of having routine MRIs versus mammograms, especially if they have a strong family history of breast cancer. So education's always the key, teaching them the technique, what to recognize as abnormalities, and to call the physicians immediately. Age-related changes are important. We need to know that the breast also includes the axillary tail because we are also assessing those lymph nodes. Those axillary lymph nodes are very important. As the nurse, you are not going to routinely do a internal or, for the most part, an external vaginal exam. That is something that the physician's going to do or the nurse practitioner. The biggest thing is really just knowing some of the normal findings as far as some of the assessment versus abnormal, because you would need to know what feels abnormal on the breast and should be sending red flags versus what should feel normal.